Assalamu alaikum and welcome to the sarcoma session of the 20th Shaukat Khanum Annual Cancer Symposium. I want to thank all my attendees and the panelists and the speakers. So without wasting time, I would move on to the first presentation by Professor David Thomas. He is the Director of King Horn Cancer Center and CEO of OMICO, the Australian Genomic Cancer Medicine. David Thomas took medical training at the University of Melbourne, which was followed by the medical oncology training, and then he went to Harvard for the postdoctoral studies. Then he came back to Australia, and currently he is the CEO of OMICO, the Gene Center. In 2018, he was the president of Connective Tissue Oncology Society. He was the head of cancer theme at the Garvan Institute. In 2018, again, he established OMICO. His research interests include precision oncology and clinical trials, somatic and germline cancer genomics with a focus on sarcomas and cancers in young adults, animal models of osteosarcoma, and cancer evolution and drug resistance. So he will talk to us about precision medicine and sarcoma, a paradigm for rare cancers.
Hello, it's a great pleasure to be able to present to this auspicious conference, and I'm grateful to the organizers for the invitation. I'm David Thomas. I'm from the Garvan Institute of Medical Research in Sydney, and I'd like to talk to you today about our approach to developing an effective research program to deliver improved health outcomes for patients with sarcomas. Rare diseases have been a problem for medicine for a long time, such that the National Health and the European Organization for Rare Diseases have come up with definitions of the frequencies of these conditions that will satisfy epidemiologic studies. And generally speaking, rare diseases are regarded as those which occur at less than 6 per 100,000 of the population in general, with less common between 6 and 12 per 100,000. For cancers, this amounts to more than 186 different cancer types. And amongst those cancer types, of course, is sarcomas par excellence. This shows some Australian data about the collective impact of rare cancers on the community. You can see on the top part of this table, the frequencies of cancers from the most frequent down to the least frequent in males and females. You can see the number of new cases diagnosed each year in the country and the number of deaths and the potential years of life lost to these diseases. The point I want to make here is that collectively more than 20,000 cancers are diagnosed that fall outside the top 10 distinct cancer types. And of these, perhaps 30% of all cancer deaths and years of life lost are attributable to rare diseases collectively. That means that using an ultra-rare definition of less than 1 per 100,000, there are more than 2,200 deaths in Australia each year. And at 6 per 100,000, the formal definition of rare, more than 14,000 deaths each year due to rare cancers. The paradox here is that rare cancers are not rare, but collectively have an enormous contribution to morbidity and mortality from cancer in our community. And what's happened over the past 30 or 40 years is that the mortality as a ratio of the incidence of cancers has dropped for common cancers, as shown in this graph. You see a progressive downward trend from roughly 40% of diagnosed common cancers causing death down to under 30%. But that's not been the case for rare cancers. In fact, rare cancer diagnoses have tended to rise over time, but the death rate has not fallen. Why is that? Well, one of the reasons is that up until recently, it's been relatively difficult to do research into rare cancers. You can see here Australian data showing the relative amount of research, the percentage of total cancer burden, and the percentage of deaths due to various cancer types. So as you can see here for breast cancer, about 22% of all research funding is spent on breast cancer, but it accounts for about 11% of the total burden of disease and fortunately about 6% of cancer deaths. If you go across to the far right, you see rare cancers, where less than 2% of all research funding is invested in rare cancers because of the statistical challenges in dealing with each of these entities individually. But you can see that the proportion of cancer deaths is around 15% and the total burden of disease is around 11%, indicating that the total burden of disease and the contribution towards mortality, again, is worse for rare cancers than it is for common cancers. So the question is, what can we do about this? Can we overcome the laws of statistics? That's pretty obviously no. But there is a change that is coming that I will talk about today. This is a summary from the organization Rare Cancers Australia, in Australia, a community-based organization, indicating the percentage of research investment of pharmaceutical benefits scheme, our government drug funding agency, and the proportion of deaths due to rare cancers, or rare and less common cancers here. You see, rare and less common cancers receive 13% of research funding, a little under 13% of pharmaceutical benefits scheme funding, but account for 1 in 2 cancer deaths in Australia. Now, sarcomas, as I said, are a paradigm for rare cancers. This is an outdated chapter list for the previous World Health Organization Atlas of connective tissue tumors. And you can see that there are approximately 50 different histological subtypes within the general definition of sarcomas, or connective tissue malignancies. And that 1% is further divided up into these 50 different subtypes, meaning that all sarcomas constitute rare diseases. And of course, each particular subgroup constitutes an ultra-rare disease. How do we tackle the problem of sarcomas? That was the question that faced me as a clinician over the past 30 years. Well, genomics has come along to change this. This is simply a paper, an image from a paper that we published about 3 or 4 years ago describing the genetics and genomics of well-differentiated and dedifferentiated liposarcoma, bringing the power of this enormously complex and rich technology to addressing the problems about the molecular classifications of cancers in general. And what that's enabled us to do in general is to change the paradigm of cancer care from a one-size-fits-all approach, the sort of approach that depends upon the frequency of histological and anatomic definitions of cancer back in the 1920s and 1940s, when we were using radiotherapy and chemotherapies to treat patients, to developing rationally designed drugs based around molecular targets, which are largely genomic, and that in turn enabling a personalized approach to the treatment of patients with cancer. And that personalized approach, or precision medicine, unquestionably has completely changed the game for cancers in general. This is a summary of some papers up until about 2 or 3 years ago, describing the response rate, the progression-free survival, and overall survival from a precision medicine approach applied to advanced cancers compared to a conventional approach. And I'd like you to focus on the second row, on the second row here, a meta-analysis of 364 single-agent phase 1 studies between 2011 and 2013. What you see is that a non-precision medicine approach in phase 1 produces the sort of response rate that we used to quote to patients who are undergoing phase 1 studies back in the 1990s, roughly 5% chance of objective response. Now that's jumped with a precision medicine approach where one is applying a drug against an individualized, personalized target that's present within the participant's tumor to over 30%. And that's associated in turn with an improved progression-free survival. And as you can see across these phase 2 and phase 3 studies and all these retrospective analyses that have been done, consistently with improved outcomes, even when the drug is being used at its very earliest phase of development. And that has in turn led, certainly for diseases like lung cancer, to a complete change in the way that we treat those diseases. Lung cancer can be regarded as a poster child for what precision medicine can possibly achieve. Here you see, for lung cancer, a disease for which there were no targets back in the late 1990s, and chemotherapies had very limited activity, that we now have more than 11 drug targets, which are found in up to 50% of all non-small cell lung cancer patients. And you see here not just the targets, but the fact that there's been enormous effort from the pharmaceutical sector in developing matched therapies for these drug targets, all of which have been identified by genomic profiling. How did we get there? We got there through innovations in clinical trials, and this just provides a quick summary over the past 5 years of innovative new trials that have been developed. You can see the Winter trial, which introduced for the first time the use of RNA profiling, particularly for fusion gene detection, as well as DNA-based profiling. The iPredict trial, which attempts to bring 2 drugs, not just 1 drug, but 2 matched therapies for each patient where possible, showed that there were improved response rate where you were able to do that. TAPER and DRUP constitute national programs which attempt to bring at large scale the benefits of precision medicine through a basket of trials to patient populations at large. Target is addressing the question of liquid biopsies, and CAPISCO is an important trial because it tackles one of the hardest problems that we've had to face in cancer, which is carcinomas of unknown primary. These are quintessentially diseases for which the old classification of cancers that we've used for drug development have failed, just like for rare cancers. And these approaches, precision medicine approaches, will have their greatest impact in rare diseases like sarcomas and diseases like cancers of unknown primary. So I'm going to talk to you now about our own Australian experience of this approach. We've set up a platform, a national precision oncology platform, which is now open at 21 centres in 7 states and has developed through a rich range of partnerships, both in the academic and clinical sector, but also importantly with industry. Of course, industry is where we obtain the drugs that we're able to deliver the benefits of precision approaches to patients. And also from the community organisations which have funded and made possible this program, along with our federal and state governments. And we're doing this as part of an international collective, along with TAPER and CAPTURE and DRUP in the Netherlands, because we know that we'll have to share and aggregate data to be able to get the insights that we need to truly advance knowledge, particularly in rare diseases. I'm a sarcoma specialist, so it was especially pleasing to see the proportion of patients with sarcomas that have been enrolled in this trial. You see to the left, sarcomas, or bone and soft tissue connective tissue tumors, comprise more than 700 cases out of the 3,900 patients we've enrolled onto our program over the past 3 years. And that's been ahead of recruitment targets, speaking to the high levels of unmet need. More than 400 clinicians across 100 institutions in Australia have referred onto this program. And many of the worst outcome cancers, like pancreatic cancers, brain cancers, lung, cancers of unknown primary and ovary, are represented amongst the most frequently referred patients, which is exactly what we want this program to do. Amongst sarcomas, you see that those 700 cases divide up into an incredibly rich range of progressively rare cancer subtypes. Probably the most common connective tissue tumors, leiomyosarcoma, undifferentiated pleomorphic sarcoma constitute the largest group, then well-differentiated liposarcoma, but going all the way around to alveolar rhabdomyosarcomas, epithelioid hemangioepitheliomas, alveolar soft part sarcomas, and desmoplastic small round cell tumors. For the first time, bringing patients for whom there would be no dedicated trials an opportunity to take part in the research enterprise. And it's through research, of course, that we bring benefits to patients. We found a range of drug targets present in these tumors simply from taking part in this genomic profiling program. You see the p53 pathway, unsurprisingly, frequently represented amongst the mutation patterns that we see in soft tissue sarcomas and bone sarcomas. Also perturbations of cell cycle, for which there are emerging drugs like palbociclib. The RAS-RAF MAP kinase pathway has a number of druggable targets present in it. The PI3 kinase pathway, for which we've struggled to make breakthroughs over the past 2 decades. The hedgehog pathway, but also pathways involved in DNA repair, like homologous recombination, for which there are drugs like olaparib now becoming available, or mismatch repair deficiency, for which immunotherapies are proving promising. And this just shows the distribution of tumor mutational burden, one of the genomic targets for which immunotherapies have been shown to be increasingly effective. In fact, there was a recent approval of pembrolizumab on the basis of high tumor mutational burden across multiple cancer types issued by the FDA in the past 18 months. You can see here that about 8% of sarcoma patients, not typically regarded as an immunosensitive disease, but about 1 in 12 sarcoma patients have an elevated tumor mutational burden, comparable to the levels that you see in melanoma or Merkel cell carcinoma in our cohort. these diseases, Merkel cell carcinoma and melanoma, are of course paradigms for immunosensitive diseases. So the question was, could we design a trial which might benefit patients with sarcoma who had increased tumor mutational burden? And so we did. We developed a doublet immunotherapy trial supported by AstraZeneca of durvalumab and tremelimumab. That trial has now enrolled 112 patients and is in follow-up. Of those 112 patients, 45 patients have sarcomas. And you can see many of these patients have had durable long-term benefit, as shown in this swimmer plot, from access to therapies. And for those patients who have an increased tumor mutational burden, as I showed you, 1 in 12 sarcoma patients do, you can see an increased long-term overall survival for those patients who receive doublet immunotherapy. And access to this trial was predicated upon the presence of a pan-cancer program, which enabled patients such as those with rare and less common cancers to take part. And here you see the benefit for sarcoma patients in taking part in this trial. We have been working very hard on providing treatments. Treatments are where all the benefits lie for our patients. And when we started the program back in 2016, we had 3 trials, including that durvalumab tremelimumab trial you see up the top here. But we've developed an increasing range of trials, now up to 20 trials for more than 950 cancer patients, many of which are, as you see above the green line here, for patients with any type of cancer, including patients with sarcomas. In fact, we've also developed specific trials for sarcoma patients, like this eribulin study for patients with advanced incurable angiosarcoma, and also this interleukin-23 targeting trial for patients with bone and soft tissue sarcomas. But you'll notice that the frequency, as I showed earlier, of mutations in the cell cycle pathway makes this particular trial here of a CDK4 inhibitor with a checkpoint inhibitor, immune checkpoint inhibitor, particularly interesting. This trial has already enrolled 28 of 32 patients over the past 18 months, and many of those patients have had sarcomas. We've developed sub-programs in lung cancer, hematological malignancies, and pancreatic cancer as well to round out the suite of approaches, because we're not just focused on solving the problems of patients with sarcoma, but we're trying to tackle the difficult problems faced by all patients with cancer. This shows a snapshot of the benefit overall from taking a precision medicine approach in general, not just for sarcomas, but really for all cancer patients who've run out of treatment options. Of the roughly 2,500 patients in this particular analysis, 461, or about 14%, had received a matched targeted therapy as a consequence of molecular screening. And the survival of those patients who've taken part in matched therapies as a consequence of the screening has been extended from 11 months in this very advanced cancer population to 16 to 17 months, depending upon exactly where they've received their treatments from. They've predominantly received their treatments not through off-label therapies or for government-funded therapies, but through clinical trials of targeted agents that are being conducted throughout the Australian clinical cancer care community. I want to change tacks now and talk to you a little bit about early detection, the other side of personalized or precision medicine, which is not just about treating patients with advanced cancer, but treating patients so that we cure their cancers at an early stage of disease. And that's, I want to illustrate that by demonstrating a particularly important gene and pathway that's important for the risk of sarcomas. This is a snapshot from a paper which is currently under review at Science, showing the patterns of mutations we see in a very large cohort of patients with sarcomas. This is what's called a graph. It indicates the relatedness between genes which bear an excess burden of mutations in a sarcoma population. And the size of the nodes in this graph represent the frequency with which we see mutations in sarcoma patients. Right at the heart of this network, and then this study was done with whole genome sequencing, so we were sampling all 22,000 genes in the human genome. The most frequently mutated gene is the p53 tumor suppressor gene. Now, the p53 tumor suppressor gene was identified as the cause of a syndrome called Li-Fraumeni syndrome back in 1989 by David Malkin and others. But the syndrome itself, Li-Fraumeni syndrome, was first described by Joe Fraumeni and Fred Lee back in 1969. It's been known for more than 5 decades. And Li-Fraumeni syndrome is quintessentially the sarcoma syndrome. Sarcomas comprise about 1 in 3 cancers seen in this devastating syndrome, in which there is a 50% chance of developing a cancer by the age of 30, and the median lifespan for patients who carry mutations in p53 is in their mid-40s. Now, Li-Fraumeni syndrome has been the orphan child in the cancer risk category. Unlike breast cancers or hereditary breast ovarian cancer, unlike hereditary bowel cancer, where very early on the clinical community learned to develop approaches to try and detect those cancers arising in the breast and bowel early through mammography or through bowel screening. That hasn't been the case for Li-Fraumeni syndrome. And that's been because Li-Fraumeni syndrome, just like sarcomas, can develop cancers at any site in the body. And so technologies needed to be developed which enabled the detection of cancers no matter where they arose. And that's only recently been developed. So what I'm going to share with you today is the results of the surveillance and multi-organ cancer prone syndromes, or SMOC+ study, which we initiated in 2012, which uses whole body magnetic resonance imaging to detect cancers wherever they arise in the body. And of course, whole body MRI is particularly effective at picking up soft tissue and bone tumors. And the purpose of this study was to estimate the prevalence and incidence of investigable lesions by whole body MRI, to determine the number and stage of cancers identified in the Li-Fraumeni population, the acceptability, safety, and psychosocial impact upon those people who are being screened, and of course, to estimate the health system's impact, because ultimately we want this technology to be introduced to clinical practice. So over the past 10 years or so, we've had more than 117 participants, the majority of whom have had Li-Fraumeni syndrome with mutations in p53. The ages have been between 18 and 66 years of age, with a mean age very young at 36 years. And you see some of the other demographics as outlined here. The summary of the findings of the study is that we've identified in this group of 120 odd patients, 32 new primary cancers detected when curable in 23 individuals, and 8 or 1 in 4 of these cancers have been sarcomas. Now, that detection rate is 5 times the detection rate for breast MRI screening that you see in women who are at high risk of hereditary breast ovarian cancer, indicating that this technology is indeed able to detect cancers in very high risk individuals, and particularly sarcomas, at a stage when it's curable. I just want to now finish off by saying thank you to those people who made this possible. The Molecular Screening and Therapeutic Study is a national program headed out of a laboratory at the Garvan Institute of Medical Research. I'd like to particularly acknowledge Dr. Mandy Ballinger, who is the cohort manager, but a whole team of individuals and all of the referring clinicians. We've set up a company, a non-profit company, to enable this National Precision Oncology Program, and the Deputy CEO of that is Dr. Vera Terry. We've been fortunate in having academic partners in the NHMRC Clinical Trial Centre in Australia, headed by John Symes, and we've depended heavily on translational oncology capacity, supported by Maya Kansara and Jim Blackburn. The SMOC study was run by Mandy Ballinger. It is now open in 7 countries across 23 cancer centres, and a whole range of the clinical genetics community across the world has been taking part in the study, as well as our colleagues in the imaging area. And of course, we've depended very generously on funding from the federal government and also from philanthropic organisations and from our state government in New South Wales to make all of this possible. So that concludes my presentation. I'd be very happy to take any questions if they wanted.
An outstanding presentation by Prof. David Thomas, and I wish Prof was with us, but as you know, Australia is 6 hours ahead of Pakistan time. So due to this time difference, he couldn't make it, but he told me that he'd be happy to take any questions and respond them by email. However, if our participants or attendees have any question, we have another medical oncologist as our panelist, so please do ask us. And this presentation well shows the magnitude of difference that the personalized medicine can make. So response rates from ranging 5% to 30% with the personalized medicine is outstanding. And we've seen how many mutation burden the sarcomas have. So Moving on to our next speaker, we have with us Dr. Attar Kazmi, our very own, my teacher, my mentor, and I still look up to him in case of any problem, and he never disappoints. So he's an excellent teacher with crystal clear ideas about the basics and a down-to-earth human being. Currently, he is working at the Department of Radiation Oncology at King Faisal Specialist Hospital and Research Center, Saudi Arabia. Dr. Attar's interests include novel approaches to neoadjuvant treatment in rectal and esophageal cancers, organ sparing in rectal cancer, neoadjuvant radiation and chemoradiation in soft tissue sarcomas, stereotactic radiation in oligometastatic disease. So Dr. Attar will talk about radiotherapy for soft tissue sarcomas.
Assalamu alaikum. Thank you for inviting me to talk about role of radiotherapy in sarcomas in this sarcoma session. We know that the management goals in sarcomas are to maximize local control and to prolong long-term survival. But in view of the peculiar anatomical location of the sarcomas, particularly in the extremities, assessment of functional outcome, long-term functional results is particularly important. Also, since a significant portion of the sarcoma patient population consists of children and young adults, the late effects of treatment are particularly important to consider. Radiotherapy for soft tissue sarcomas has been around for a long time, but really came into its own with the publication of the seminal trials in the 1980s and 90s. When Rosenberg showed that limb-sparing surgery plus radiation offered similar outcomes to more ablative surgery like amputation. And with these sort of studies, the surgical paradigm has gradually shifted that in the 80s, when the vast majority of patients underwent amputation and ablative surgery, now less than 10% of patients do so. Also, further studies showed that limb-sparing surgery plus radiotherapy offers better outcomes in terms of local control than limb-sparing surgery alone, and therefore radiotherapy is now an important part of multimodality treatment for extremity and truncal soft tissue sarcomas. But should all soft tissue sarcomas of the extremities and trunk get radiotherapy? Essentially, patients with high risk of local recurrence are advised multimodality treatment, but the assessment of local recurrence risk is complex. A number of factors, including surgical margins, grade, tumor size, anatomical location, and histopathological subtype, have an interplay in assessing the risk of local recurrence. Surgical margins are by far the most robust parameter and indicator of local control, but other factors are important too. Also, even in tumors that are smaller or low grade, the consequence of recurrence, impact on functional outcome, and the potential morbidity of future surgical salvage options are things that one needs to think about before deciding about surgery alone versus combination of radiotherapy. And therefore, a multidisciplinary team discussion is critical that comprises of the orthopedic surgeons, the radiation oncologist, the medical oncologist, and also occupational therapist to look at the long-term outcomes. A number of groups have tried to objectively define the risk of recurrence and therefore make selection of multimodality treatment more consistent. For example, this nomogram looks at age, more than 50, less than 50, size, more than 5 centimeters, less than 5 centimeters, margins negative or close or positive, high grade, low grade, and various histologies, and allocates points according to this, and therefore attempts to predict the risk of local recurrence. ASTRO guidelines that came out earlier this year state that for patients with primary localized extremity and truncal soft tissue sarcomas, for whom an oncological resection is planned, radiotherapy is recommended for those at increased risk of local recurrence. And that the assessment of risk of local recurrence is complex and incorporates multiple factors. And therefore, potential morbidity of future surgical salvage options must be considered. It also recommends combined modality radiotherapy for patients for whom a close or microscopically positive margins are anticipated at the time of surgery. Patients who have already undergone resection, if they have unexpected close or positive margins, then radiotherapy is usually indicated, although a resection may be planned first. And following unplanned excision or further oncological resection is planned, it recommends radiotherapy before the second surgery. Radiotherapy may be omitted in smaller tumors less than 5 centimeters that are usually low grade and are superficial to the fascia if wide surgical margins are obtainable. ESMO also recommends perioperative radiotherapy with wide excision in high-grade sarcomas that are deep and larger than 5 centimeters. So what is the best timing of radiotherapy? Is it should be given pre-operatively or post-operatively? The traditional paradigm of radiotherapy with sarcomas has been post-operative radiotherapy. This trial looked at comparing pre-operative versus post-operative radiotherapy and randomized resectable high-grade T2 to 4 and grade 2 to 3 sarcomas treated with either pre-operative or post-operative radiotherapy combined with surgery. The pre-operative radiotherapy was 50 gray in 25 fractions versus post-operative radiotherapy that was 60 to 66 gray in 30 to 33 fractions, and was powered to detect a decrease in wound complication rate for pre-operative radiotherapy in 30%, but it was stopped early because of the higher rate of acute wound complications in the pre-operative radiotherapy group. In final analysis, there was no difference in local control, progression-free survival, or overall survival in the pre-operative and the post-operative group, but the toxicity profile was considerably different in both the groups. Patients who have pre-operative radiotherapy had a higher wound complication rate. That was almost double than the patients with post-operative radiotherapy. It was particularly more pronounced in the lower limb, and there was a bias towards secondary closure with pre-operative radiotherapy. The acute wound complications, however, were reversible and temporary and manageable. Post-operative radiotherapy, on the other hand, had a higher risk of late radiation toxicity, particularly fibrosis and skin atrophy. And it showed that the grade 2 radiation dermatitis was very high, and late quality of life was significantly worse in patients who received post-operative radiotherapy as compared to pre-operative radiotherapy. So this table summarizes the pros and cons of the two approaches. In terms of planning, neoadjuvant or preoperative radiotherapy is easy to plan because there's a visible tumor. You can outline it accurately, give appropriate margins. The normal tissues are pushed away by the tumor, and therefore they get less radiotherapy. The doses employed are relatively low, in the range of 45 to 50 gray. The treatment time is shorter. There's a potential for hypofractionation and exploiting the biology of the sarcomas, which tend to have a lower alpha beta ratio, and therefore there are theoretical advantages to hypofractionation. And there's a potential to downsize the disease and improve the threatened surgical margins. You can also assess potential tumor response and radiosensitivity with the preoperative radiotherapy. The acute wound complication risk is higher, but this is really manageable and temporary, while the risk of late toxicity is lower. Post-operative radiotherapy, on the other hand, planning is difficult because there's no visible tumor, and you end up imagining the tumor in the surgical bed. We have to include the tumor bed, the scars, the drainage site, the operative route, and give appropriate margins for this, and therefore the target volumes are considerably higher in post-operative radiotherapy compared to the pre-operative radiotherapy. The healthy tissues have fallen back into the surgical bed, and this, coupled with the large volumes, results in a significant irradiation of normal tissue to a higher dose, because you need a higher dose of 60 to 66 gray in post-operative radiotherapy to adequately provide local control. And therefore, there is a high risk of late toxicity that's progressive, irreversible, and has a significant effect on long-term quality of life and functional outcome. So based on these considerations, more and more centers have moved on to pre-operative radiotherapy now, recognizing that modern radiotherapy techniques reduce the wound complication rate, and also wound complication rates are generally manageable as opposed to the late toxicity and progressive fibrosis. The ASTRO guidelines recommend that for patients with primary localized extremity and truncal soft tissue sarcomas, where surgery and radiotherapy are indicated, pre-operative radiotherapy is recommended over post-operative radiotherapy. Post-operative radiotherapy is conditionally recommended in specific clinical circumstances, for example, uncontrolled pain or bleeding or fungating tumor, or when the risk of wound healing complications outweighs that of plate toxicity. So this algorithmic approach taken from the ASTRO guidelines shows that for extremity and superficial truncal sarcomas, there should be a multidisciplinary evaluation for appropriate oncological management. This involves the assessment of local risk recurrence, local recurrence risk. If the patients have a high risk of local recurrence, usually radiotherapy is recommended, and pre-operative radiotherapy is recommended over post-operative radiotherapy. These patients go on to have oncologic resection after that. If there are unplanned positive margins, one can consider a post-operative boost of 10 to 16 gray in selective situation. Post-operative radiotherapy is an alternative option in these patients, but usually should be employed in specific clinical circumstances like fungation, bleeding, or uncontrolled pain, or when the risk of acute wound complication is so high that it outweighs the risk of toxicities. Patients with low risk of local recurrence, if surgical margins can be achieved, negative margins can be achieved, then they really go on to have oncological resection. However, even for low risk of recurrence, if the risk of positive or closed margins, these patients should be treated with preoperative radiotherapy. Patients who have unplanned positive margins at the after upfront surgery should be considered for initial resection. If that is feasible, that should be carried out, followed by further post-operative therapy. If the margin is negative, then they can be followed up without any further treatment. So, what is the optimal dose and fractionation of pre-operative radiotherapy? The trials have usually employed 50 gray in 25 fractions. That's the standard treatment, and that appears to give fairly good downstaging and a local control that is equivalent to high doses of post-operative radiotherapy. However, sarcomas have a lower alpha beta ratio, and therefore theoretically they could benefit from hypofractionation, giving a bigger fraction size over a short duration of time. And there have been a number of studies looking at this approach, looking at hypofractionated radiotherapy of a shorter duration, ranging from 30 gray in 10 fractions to as high as 30 gray in 5 fractions. The benefits of this approach is that it gives you a shorter treatment time. It probably increases radio sensitivity, as the higher fraction can overcome the relatively low alpha beta ratio and radio resistance of sarcomas. These are all small studies. The local controls are quite impressive in these studies, ranging in the late 80s up to 100%. But at the moment, there are no randomized data comparing standard fractionation to hypofractionation. Therefore, this is an area of active research. The other question is, should all sarcomas receive the same dose of radiotherapy? Sarcomas, as you know, are a heterogeneous group of tumors and can vary considerably in their radiosensitivity. For example, myxoid liposarcomas are more radiosensitive than traditional soft tissue sarcomas, and therefore this prospective trial looked at myxoid liposarcoma of the extremity or trunk and aimed to give them a low dose of radiotherapy of 36 gray in 18 fractions and looking at outcomes. And it showed that even with a low dose, there was excellent pathological treatment response in more than 90% of patients, and local control was 100%. The rate of wound complication was reduced as compared to the historical controls in other preoperative trials, and therefore this is something that one should consider when treating more radiosensitive histologies, particularly myxoid liposarcoma. Radiation oncologists treating sarcomas were relatively slow to adopt the more advanced radiation techniques with IMRT or tomotherapy, mainly because standard 3D conformal radiotherapy provided fairly good outcomes, was useful in sparing the non-involved compartments in the limbs, and avoided the risk of circumferential radiation of the limb, causing late edema or constrictive fibrosis. So there was a worry that by using IMRT or tomotherapy, although you could conform better to the tumor volume, you ended up giving a high integral dose to the patient. This trial, RTOG06030, compared patients with upper and lower extremity soft tissue sarcomas receiving either 3D or IMRT radiotherapy to a dose of 50 gray. And it showed that there was a significant reduction of late toxicities in patients with extremity soft tissue sarcomas who were treated with image-guided conformal radiotherapy compared with the conventional 3D radiotherapy, and this was better than historical controls. Further retrospective studies have also shown that the local control is equivalent with IMRT and more advanced techniques, and the acute and late complications are less marked with these technologies. And therefore, most centers have now moved on to image-guided intensity modulated radiotherapy or tomotherapy for sarcomas. A word about definitive radiation for unresectable sarcomas. In situations where the tumor is unresectable, locally advanced, or when patients decline surgery, there is a body of evidence, mostly retrospective studies, looking at treating these patients with radical radiotherapy. As I've said before, sarcomas are considered relatively radioresistant tumors, but studies have shown that doses in excess of 63 Gray can provide a reasonable local control of up to 60%. Doses less than that have a poorer local control, therefore are usually not recommended. Combination of 60 Gray of radiotherapy along with ifosfamide has also been studied and provides excellent local control of up to 70% at 5 years, and therefore this is an option in patients who are unresectable. Moving on to retroperitoneal sarcomas. We know that most of the retroperitoneal sarcomas present at a late stage because they're often asymptomatic for long periods of time, and therefore the median size of presentation is usually 15 centimeters or more. The majority of them are liposarcomas, but Lyme sarcomas and other histologies are present in 40% of patients. Surgical resection is the cornerstone of therapy, but due to the extensive nature of the disease, it often involves extensive resection with involvement of visceral organs, and positive margins are common. And therefore, there is a significant risk of local recurrence and distant metastases. Adjuvant radiotherapy and chemotherapy are controversial, and although pre-operative radiotherapy has traditionally been employed, studies looking at its benefit are few and far between. Generally speaking, post-operative radiotherapy is discouraged as there is a huge risk of causing toxicity, and due to the abdominal viscera, particularly intestine within the field, a meaningfully high dose of radiotherapy is really difficult to deliver. Most studies of radiotherapy in retroperitoneal sarcomas have given pre-operative radiotherapy combined with either intraoperative radiotherapy or brachytherapy at the time of surgery. And the real doses are 45 to 50 Gray of external beam radiotherapy, followed by 10 to 15 Gray of either catheter associated brachytherapy or intraoperative radiotherapy. American College of Surgical Oncologist trial looked at testing more conformal radiotherapy with IMRT along with IORT in patients with retroperitoneal sarcomas, but this trial was closed earlier due to poor accrual, and it showed that with this sort of technology, you can achieve a local control of in about 74% and overall survival of 72%. URTC published this trial last year, a randomized trial, one of the few in sarcomas, a randomized trial of pre-operative radiotherapy, 50.4 Gray with IMRT plus surgery versus surgery alone. Randomized almost 250 patients of any histology that were deemed resectable at baseline staging. The primary endpoint was abdominal relapse-free survival, and it looked at either radiographic local progression or distant progression, peritoneal metastases, or microscopic disease left at surgery, or local relapse. Results showed that median abdominal free relapse survival was similar in the no radiotherapy versus radiotherapy group. The 3-year survival, the 3-year modified survival was similar, except for a subgroup analysis in liposarcomas when radiotherapy appeared to have a better outcome than non-radiotherapy patients. The 3-year overall survival was similar in both the groups. The toxicity in STRAS trial in the radiotherapy plus surgery group was significantly more than the surgery only group. The vast majority of patients experienced lymphopenia. Some patients experienced anemia and hyperalbuminemia, and overall serious side effects happened in about a quarter of the patients, and there was one treatment-related mortality. There are a number of criticisms of this trial in that it probably used a lower dose of radiotherapy than is optimally required for control of downstaging of soft tissue sarcomas in the retroperitoneum. There was a high rate of protocol violation, and there was significant toxicity. There's possibly a benefit in the subgroup patients with liposarcoma, but we do not have enough follow-up to make this a certain conclusion. And therefore, based on this trial, conventional preoperative radiotherapy of 50 Gray is at present not recommended for patients with retroperitoneal sarcomas who have a resectable disease. Although patients with locally advanced disease and unresectable disease probably still need downstaging before this. Whether this is beneficial or not is an open question. So where do we go from here? And the answer is probably the use of more conformal techniques or the use of protons to better spare the organs of risk, and the possibility of dose escalation. So this trial is looking at 50 Gray in 25 fractions, along with a simultaneous integrated boost of up to 57.5 Gray. And this boost to the higher risk CTV is marked in conjunction with the surgical discussion, where there is a risk of positive surgical margins at the time of surgery, and then this area is given a higher dose. So it will be interesting to look at this outcome of this trial in a few years' time and see whether radiotherapy can become part of the routine management of retroperitoneal sarcomas. At present, it is not. Just turning our attention to the metastatic sarcomas. Sarcomas metastasize commonly to the bone or lung, and traditionally oligometastatic disease in fit and young patients was treated with lung resection. However, with the publication of SABRE trial and the NHS SABRE outcome data last year, there is more interest in using stereotactic radiotherapy for oligometastatic disease. And this retrospective review looked at sarcomas with pulmonary metastases and gave them a dose of 50 Gray in 4 or 5 fractions. And the local control at 12 and 24 months was fairly impressive, 94% and 86%, and the overall survival was also quite good. The toxicity was fairly limited. Only 3 patients developed grade 2 chest wall toxicity, but there was no other significant toxicity. And therefore, stereotactic radiotherapy for oligometastatic disease appears to be a promising modality. And EORTC is running this trial of stereotactic radiotherapy in addition to standard of care in rare cancer with oligometastatic disease. The selection is stable primary tumor with 1 to 5 oligometastases. These are randomized to either standard of care or standard of care plus stereotactic radiotherapy. And they're stratified according to the number of metastases, disease-free interval, and the type of systemic therapy that has been given. The dose fractionation can be either 20 Gray single or 30 Gray 3 fractions or 35 Gray 5 fractions. And therefore, it will be interesting to look at the outcome of this trial in due course. Just the last couple of slides about some interesting developments on the fringes of multimodality sarcoma treatment. Hypothermia has been known for a long time to increase the radiosensitivity of the tumors, but there have been limited work in sarcomas regarding this. We do know that hypothermia improves blood flow and therefore reduces hypoxia in the tumors, rendering them more radiosensitive. But so far, the studies in sarcomas have been fairly small and limited. This Polish trial is looking at resectable or marginal resectable tumors, as well as non-resectable tumors, and aims to give them hypofractionated radiotherapy of 12 Gray in 3 fractions to the marginal resectable and a boost to the unresectable tumors. And this is accompanied by deep hypothermia twice a week. And they're looking at late adverse effects and local control, as well as progression-free survival. So it'll be interesting to look out for the results of this trial and see whether hypothermia can be incorporated in the standard treatment of soft tissue sarcomas. Just this last slide, looking at an interesting development regarding nanoparticles being used as radiosensitizers. So this study looked at investigating the efficacy of hafnium oxide, which is a nanoparticle, as a local sensitizer to neoadjuvant radiotherapy. So locally advanced resectable soft tissue sarcoma of the extremities of the trunk wall who were deemed appropriate candidates for pre-operative radiotherapy were randomized to radiotherapy alone, 50 gray and 25 fractions, or radiotherapy plus a single intratumoral administration of this nanoparticle. And the primary endpoint was complete pathological response. And the analysis of 176 patients in this trial showed that there was a statistically significant difference in the pathological complete response between the patients receiving the nanoparticle injection compared to the radiotherapy alone group. So 14 patients had a pathological complete response compared to 7 patients in the radiotherapy only group. The R0 resection was also more frequent in the radiosensitizer arm, and the toxicity was manageable. So these are some, this is an interesting emerging technology in the soft tissue sarcomas, and I think we'll be watching this space with interest in the future. So in conclusion, radiotherapy is an integral part of management for the majority of patients with soft tissue sarcomas. Patient selection for radiotherapy is complex and requires an MDT assessment. For extremity and truncal soft tissue sarcomas, pre-operative radiotherapy has advantages over post-operative radiotherapy and is usually recommended. Intensity modulated radiotherapy and advanced techniques like thermotherapy provide equivalent local control and reduce toxicity, and therefore are now considered the standard of care. Resectable retroperitoneal sarcomas can be managed with surgery alone without radiotherapy, and complementary technologies like particle therapy, hyperthermia, and nanoparticles may provide further opportunities for improved outcome in the future. Thank you very much for your attention.
Thank you, Dr. Attar. An outstanding talk as usual, and thank you for making it. I know you have a busy schedule, but you are here with us. And for the participants, if you have any question regarding the radiotherapy part of sarcomas, please do ask him, because Dr. Attar will be with us during the case discussion. So moving on, our last speaker is another distinguished person from UK. Professor Lee Jays is a consultant orthopedic surgeon at Royal Orthopedic Hospital NHS Trust. He's a professor of health and life sciences at Aston University. Professor Jays specialized in the treatment of bone and soft tissue sarcomas. There are more than 100 scientific papers in the world's top impact factors journals under his belt, and he has written 3 chapters in the orthopedic section of surgery books. He regularly lectures around the world on joint replacement and tumor surgery, and also a reviewer of for BJJ, the official journal of British Orthopedic Association. Professor Jays sits on several national committees, including the National Cancer Research Institute and National Cancer Intelligence Network. So today he will talk about the recent advances in sarcoma surgery.
Hello, my name is Lee Jays, and I've been asked to give a talk about recent advances in sarcoma surgery, and thank you very much for asking me to speak at this meeting. I'm a consultant orthopedic surgeon in Birmingham, which is one of the largest sarcoma services in the world and one of the largest arthroplasty units in the UK. We're pretty academic, and we publish approximately 20 to 30 papers per year on arthroplasty and oncology, and we're members of several international organisations responsible for oncology. And occasionally I enjoy doing endurance events, though often not when I'm doing them. The Royal Orthopedic Hospital in Birmingham is based in the second city in Birmingham. It was originally founded in 1909 and was originally called the Cripples Union and was originally owned by the Cadbury's chocolate factory. It then became a TB hospital because it was in the middle of the country in the days gone by, and now it's one of the largest purely orthopedic hospitals in Europe. We have 14 operating theatres, only doing oncology, only doing elective orthopedics and no trauma, and we have a catchment population of 22 million for sarcomas and 5 million for revision surgery. England has a population of approximately 55 million, and we look after about half of that population, and we look after about 5 million people for revisions. We do approximately 2,000 joint replacements and 350 revisions per year, and we take referrals on 4,000 suspected sarcomas per year. In 2014, we discussed 2,800 cases. We diagnosed 600 new bone tumours, of which 187 were primary bone tumours, and we did 32 pelvic sarcomas. We looked after 600 new soft tissue tumours, and we have 8 all-day theatre lists for oncology per week, and we now have data on over 5,000 bone sarcomas and 50,000 referrals. You can see that we take most of our referrals from the middle part of the UK, but we also have some extended referral networks. It's pretty unusual and gets me into positions that most orthopedic surgeons don't do, and I spend most of my time undertaking complex pelvic surgery. We've been lucky enough to be invited to work at a national level with the UK government as well. So what's the plan for today then? The plan is, we could talk about lots of different topics, but I wanted to give you an update on bone sarcoma margins, an update on computer navigation, and an update on 3D printed implants, as I think these are 3 interesting topics. So the question is, can we really make a difference in what we do? Albert Einstein used to say that if you always did what you did, you will always get what you got, and therefore we have to look at things in a new way. We all know the Anakin staging system, which was originally published in 1981, and it only had 40 patients with soft tissue sarcomas of the thigh. The tumours margins were classified by their relationship to the pseudocapsule of the tumour, and limb salvage was only undertaken in 12 patients. The rate of local recurrence was 50% after a marginal resection, 25% after a wide resection, and 4% after a radical resection, though these margins were never really described in detail. And the trouble is that literature at the moment tries to mix and match definitions. And what we really need is clear definitions of what a wide margin and a marginal margin are. 2 great founders of orthopedic oncology in the UK, Sir Rodney Sneath and Sir Rodney Sweetnam, said that any fall can cut off a leg, but it takes a surgeon to save one. But the question is, what is a safe margin? Clearly this bridge here being crossed over the river is a margin. We're away from the river, but it's not a very safe margin. Whereas this bridge, which looks dangerous, is actually very safe. So which margin should we achieve? When we asked the literature, the American group talk about a tumour-free margin. At the Royal Orthopedic Hospital, we try to get a 1 centimetre margin, and in Japan they talk about 2 centimetre margins. However, when we asked a group of international surgeons what they regard a wide margin is, you can see that there was complete equipoise in whether it should be tumour-free, 1 millimetre, 1 centimetre, or 2 centimetres. But when we look at the results for those 3 different areas, you can see that our local recurrence rate is all very similar, despite calling margins different and different units getting higher adequate margin depending on their definition. So we decided to look at margins in osteosarcoma, and we only looked at the response to chemotherapy, the surgical margin, and were interested in the rates of local recurrence, as there was a debate between what was a safe surgical margin. We used the Anakin and MSTS classifications, even though these were very subjective. And then we looked at the margin in millimeters achieved. When we look at this graph, we can see a table, we can see that if we use it by the traditional MSTS margin, there was a clear difference between radical and intralesional, but there wasn't any statistical difference between wide and marginal margins. We came up with a classification system where we used a receiver operating curve to work out what the best predictor of margins in millimeters was, and this appeared to be 2 millimeters. But we actually found that the best predictor was a combination of the margin in millimeters and the response to chemotherapy. We developed 4 groups. Group 1 was a good margin and a good response to chemotherapy. Group 1B was a poorer margin under 2 millimeters but a good response. 2A was a good margin but a poor response, and 2B was a poor margin and a poor response. When we look at the graph, we can now see that these 4 groups in terms of local recurrence clearly stratify quite nicely the risk of local recurrence over a period of time for osteosarcoma. And when we looked at these groups in terms of percentages, you can now see that 1B and 2A come out clearly, and that's a nice stepwise group in terms of local recurrence now. We also wanted to look at what we should do when the vessels are close, and therefore we decided to come up with another study. Here we looked at 226 patients with high-grade non-metastatic osteosarcoma, and we looked at where the vessels were in relationship to the tumour. On the MRI scan, were they more than 5 millimeters away, between 2 and 5 millimeters, less than a millimeter, or type 4 where they were surrounded. We found that the margins we could achieve were surprisingly greater than we thought, at 6.9 millimeters, 3 millimeters and 1.4 millimeters for the groups 1 to 3. Interestingly, when we looked at the local recurrence-free survival, it was significantly worse in the type 3 where the tumour was applied to the vessel than the amputation. However, there was no overall survival benefit in having an amputation in this group compared to a resection. Factors in this group, such as response to chemotherapy, limited vascular attachment to less than half of the circumference of the vessel, or attachment by less than 10 millimeters, reduced the risk of local recurrence. Here we can see in this table that in the type 3, though they were relatively equally distributed between amputation and limb salvage, you can see that the margins were only intralesional in a small proportion, and that the overall survival was no different between amputation. And you can see that the local recurrence-free survival on the top left was better with an amputation, the overall survival made no difference. So what about chondrosarcoma then? We looked at 343 patients who'd had either a pelvic or extremities chondrosarcoma, and we worked out their local recurrence being dependent on both margins and grade of tumour. With the increasing histological grade, we needed a wider margin. So a 4 millimeter margin gave us the lowest risk of local recurrence in grade 2 or grade 3 tumours. Intralesional resections led to higher rates of local recurrence in purely grade 1 tumours. Here we can see that in grade 1, that if we're clear of the tumour, then we have pretty equal local recurrence rates. In grade 2 tumours, you can now see that there's clearly a benefit in having a wider margin. And in grade 3 tumours or dedifferentiated chondrosarcomas, you can see that really we need to be aiming for a 4mm margin in these difficult tumours. But the question is, does local recurrence have any effect on overall survival? When we looked at local recurrence on disease-free survival, we showed that patients who had local recurrence died quite quickly after their local recurrence. And when we looked at the survival by local recurrence in grade 1 tumours, which were purely grade 1, there was no difference. But in grade 2, there was a very large difference between whether they survived or not. In grade 3 tumours, the same, and also in dedifferentiated chondrosarcomas. We wanted to see if this was a real effect, and when we did a competing risk model, you can see that for grade 2, grade 3 and dedifferentiation, local recurrence negatively affects survival. And here again you can see the hazard ratios, and that for grade 2 chondrosarcoma, local recurrence has a 16 times higher risk of dying. So just because we can get close to the tumour doesn't mean that we should. Okay, let's move on to Ewing sarcoma. What do we know about this? We know that radiotherapy alone has a poorer local control and survival compared to surgery and radiotherapy. But how important is local control in Ewing sarcoma? We looked at 388 patients with non-metastatic Ewing sarcoma, and again you can see that if you had no local recurrence, the survival was comparatively good. If we got local recurrence and then metastatic disease after, this was bad, and clearly having metastatic disease and local recurrence at the same time was even worse. So that would suggest that keeping local control in Ewing sarcoma is very important. As a case example, I can show you a 13-year-old boy with a fibula Ewing's. This is his MRI scan at presentation. He has an excellent response to chemotherapy, and the surgeon then has to make a debate. Should they go for a marginal margin where the tumour is going to be resected with a small amount of tissue, or should they go for a wide margin? The surgeon chose to use a conservative margin to preserve the common perineal nerve. The pathologist told him that the margins were clear and that the response to chemotherapy was 100%. But unfortunately, the patient didn't receive any post-operative radiotherapy because the margins were good and the response to radiotherapy was good. And the patient unfortunately developed local recurrence very shortly afterwards and then died. So we looked at the risk factors for local recurrence. In 388 patients, 15% had local recurrence. The 5-year local recurrence-free survival was 83%. And for limb tumours, local recurrence was affected by intralesional and marginal resections, but not necessarily by response to chemotherapy. The radiotherapy in those who had a marginal resection reduced their risk of local recurrence very significantly. And local recurrence affected the overall survival. For extremity tumours, radiotherapy decreased the risk of local recurrence. When we looked at this group of patients who had surgery and radiotherapy, we found that in the limbs, that if the patient had a wide resection, then there was less benefit from radiotherapy. However, if the patient had a marginal response to, a marginal margin, but had a poor margin, or had a good margin, but didn't receive radiotherapy, the risks of local recurrence were much higher. Here we can see it in a graph. that if we have a marginal margin and no radiotherapy, the results are as bad as intralesional. This expression of our series was also backed up by the results of the Ewing's 99 study, where patients were randomized to undergo surgery after chemotherapy, and then they were looked at competing risks for local recurrence. The impact of post-operative radiotherapy was investigated, and it was found that 25% of the patients received post-operative radiotherapy. In the forest plot here, you can see that if the patients had a good or bad response to chemotherapy, but they received radiotherapy, their risk of local recurrence was significantly less. And overall, if the patients received post-operative radiotherapy, their risk of local recurrence was less. And maybe this is because when we give the pathologist the tumour with a close margin, we don't necessarily see the viable cells which are maybe left in the surgical bed. We also look quite carefully at our treatment algorithm since 1998 for over 20 years for 50 pelvic Ewing sarcomas. They were either treated along the Ewing's 99 protocol, where radiotherapy was only given if they had poor response to chemotherapy or poor margins, or on the Ewing's 2012 protocol, where patients all received pre-operative radiotherapy. And then we looked at their risk of local recurrence. We found that for those patients that we chose whether to give radiotherapy to, those patients that we gave radiotherapy to for poor margins or poor necrosis did significantly worse than those that we chose to give as a whole group pre-operative radiotherapy. The non-selective radiotherapy group had significantly better local recurrence-free survival at 88% compared to 66% whether we chose to give them or not. We also found that the majority of the patients who had pre-operative radiotherapy had good response to chemotherapy because they'd also had the radiotherapy and were more likely to have widely excised tumours. But this meant that our surgical strategy could change as well, because we planned the resection of the tumour based on the post-radiation volume, whereas we didn't have to excise the ghost volume, which would have been there before radiotherapy. So in this tumour, we can see that we would normally have resected this area, but now after radiotherapy, we only have to resect this area. This meant we had a higher proportion of surgical margins, making surgery technically easier without having a risk of local recurrence. So less resection and lower morbidity. There was no difference in the wound complication rates between whether we had pre-op radiotherapy or no radiotherapy, and patients were initially more likely to have no reconstruction, but we have started to reconstruct them now. There is some evidence that proton therapy helps. So we tend to sterilise the tumour bed with radical surgery and or radiotherapy. We also published on chordoma, and we showed that the addition of radiotherapy significantly reduced a local recurrence in this group as well. So now we know what margin we want. How do we achieve it? And the answer in Birmingham's case is with navigation. This study looked at cases where you did a pelvic resection on a computer model, and it showed that experienced surgeons were only able to achieve an adequate margin in 50% of cases on a computer model. Navigated resection involves creating a 3D model of the patient, fusing the MRI and the CT scan, and then the model is matched to the actual patient by comparing anatomy. How do we plan a case? We use the OrthoMap 3D, and we often use custom-made implants where we send the images to the engineers. So here we are importing an image, and here we are fusing that image so the two overlay. Then we check the fusion to make sure that they're well aligned. Then we tell the computer where the tumor is by drawing around the tumor. Until we have a segmented tumor. Now we plan our resection planes. And you can see here we decide where the edge of the tumor is, and we decide where we want to cut the we are going to bone. Then we identify the anatomical landmarks which we are going to identify at surgery. And we end up with a plan of the tumor. We send that plan to the engineers, and they can have video conferences with us, and we end up exporting their models and putting them back into the plan of our computer navigation. At surgery, we find the landmarks that are easily identified, and we match these to pre-planned areas on the plan, and that we improve the accuracy by then doing surface matching from the shaping of the bone. And our registration error should be less than 1 millimeter. Here, this is how we plan the case in theatre. The computer needs to be able to see the patient tracker, which we attach to a fixed bony landmark on the area close to the area we're going to resect. We then set up the system by registering the probe. And then we undertake matching, and you can see that our initial registration area is approximately 6 millimeters. We then refine that by rubbing the probe over the bone and taking between 50 and 150 points. And then we end up with a registration error, in this case of 0.8 millimeters. We then check that the plan is accurate by checking where we are on the bone. And we can use this system called tumor collision warning, which will automatically tell us if we get within 5 millimeters of the tumor. And here we have the resection margins for this telangiectatic osteosarcoma that we saw planned there with a 1.8 millimeter margin. At surgery, we can be like the wise monkeys. We use the navigated osteotomes, which we can then see how far we are in the bone, and we make drill marks to define points on the pelvis, and then when it's safe, use a power saw. Here we are doing a sacrectomy, and you can see that we've preserved the nerve roots, and this is the resection margin on the chondrosarcoma. Excuse me. Here you can see the resected specimen is very similar in shape to the custom-made implant, which has meant that we're able now to use our more complex reconstructions. These are much more accurate and actually go where the engineers planned them to. Why do I think that navigation makes a difference? The margins, the approach, the reduction in complications, the better function, and improved survival in chondrosarcoma. The first paper we published, we only had an 8% intralesional rate, which was significantly lower than the 29% rate we had previously in the pelvis. We were able to do more complex operations. This paper for periacetabular chondrosarcoma showed that we reduced our intralesional rate from 19% to 8%, which also resulted in half the rate of local recurrence. This paper, we had no local recurrences in the navigated group compared to 12% in the non-navigated group. In this paper, we only had 22% risk of local recurrence compared to 50% in the non-navigated group. And in this paper, we show that the intralesional rate was 8.7% and the local recurrence rate was 13%, which was significantly lower than previously. In this paper, we showed that the complication rate fell from 50% in the non-navigated group to 9% in the navigated group. And you can see that the navigation reduced dislocation and, interestingly, infection. This paper looked at, again, dislocation rate in periacetabular tumours, which was significantly reduced in the navigated group. And the functional outcome in the navigated group was significantly higher. Perhaps the biggest thing that we found is that in this long-term study follow-up, the 5-year disease-specific free survival was 76% in the navigated group and only 53% in the non-navigated group, and the progression-free survival was 62% in the navigated group compared to 28% in the non-navigated group. These were all statistically significant. We've also shown significant survival, increase in survival in iliosacral tumours. The final thing that I wanted to talk to you was about additive layer manufacturing. We use the implant cast EPOR, which is a porous metal made out of 3D printed titanium with electron beam melting. It is not a coating, it's an integral part of the implant, and it's designed to work like bone and it's designed to resemble bone. It has the strength of metal but the flexibility of bone. It's based on a scanning electron micrograph of trabecular bone. It has 3D printed titanium, which are made up of tiny rods, which are arranged in a random pattern to form pores between 100 and 500 micrometers. And this is ideally suited to bone ingrowth. It has similar properties to trabecular bone, but it's an integral part of the implant and it can be placed anywhere. And you can have solid areas or porous areas, and it's cheaper to produce than trabecular metal. We've been using this in cups and in tumor prostheses and a variety of other areas. So it gives us fixation where we have very little bone. Here is a custom-made hemipelvic design with an E-port implant surface. Here you can see the resection. You can see the very close fitting of the implant to the cut surface of the bone. Here is a post-operative X-ray, and here is the patient 4 years later. This is a 52-year-old submariner with a chondrosarcoma of his P2. We did a custom-made implant for him. This is the design. Here it is at surgery using a combination of navigation and jigs with the on-growth surface. Here is the post-operative X-ray showing excellent placement against the bone. This is the X-ray 5 months later showing that it's still integrated. And here is the patient with an excellent level of function at about 5 months from surgery. In this situation, we've used a pedestal cup, which has failed over 6 years, leaving us very little bone stock. We were able to use detailed computer planning to resect a small area bone to give us some fresh bone. Here we have very complex arrangement of screws to avoid the sacral foramen, and that detailed planning makes sure that there's no damage to the nerves. Here we are at surgery again with jigs and navigation and the custom-made implant, and the post-operative X-rays show that the position is perfect without any damage to the nerve roots. In conclusion then, we have recent advances in Birmingham that mean we understand what margin we should be trying to achieve, that we have the tools to achieve that planned margin, and the results that we've done have shown reduced local recurrence, complication rates, and improved survival in chondrosarcoma using navigation. We now have improved implants which provide better fixation, function, and possibly long-term implant survival. Innovations is extremely important in orthopedic oncology, and I thank you for your attention. I apologise that I'm unable to be with you today, but I hope you found the talk was useful.
Again, an excellent presentation. It was such a dry topic, but he made it so simple and so understandable that, like myself, a person who's not a surgeon, I couldn't take my eyes off his slides. Excellent presentation, I would say. So towards the end of the session, we have a case presentation, a difficult case which we encountered, and we together we treated him. As has already been said, sarcomas are a heterogeneous group of tumors, and it is this diversity which makes the importance of a multidisciplinary team. So we have eminent people as our panelists today. I would like to introduce I've already talked about Dr. Atar Kazmi, and I owe every bit of my knowledge to him. And if I'm treating sarcomas, it is all because of him. We also have with us Dr. Kausar Bano. She's Associate Professor of Medical Oncology at Jinnah Hospital. She's a supervisor under the CPSP, and she has multiple papers under her name. Dr. Sajid Mushtaq is with us, and he is our senior histopathologist. He has special interest in sarcomas, and Dr. Sajid Mushtaq and Dr. Usman Hassan are the two people whom we trust a lot. And I can tell you that whenever the histopathology reports given by him have been sent abroad, believe me, even the histopathology people over there, they gave the same reports. Then we have Dr. Ilyas Rafi, our senior orthopedic surgeon, and Dr. Ahmed Shoaib. He joined us a few years back. And these two guys, they are working in complete harmony. And I've never seen surgeons working in such an exemplary way, the way these two people are doing. We have Dr. Kashif Siddiq, the HOD of radiology department. He's an excellent radiologist and with a specific and special interest in sarcomas. And Dr. Kashif is one of our core members of the sarcoma MDT. And whenever Dr. Kashif says that this 2 millimeter lung nodule looks suspicious, maybe 3 or 6 months down the lane, that lesion proves to be a metastatic disease. So we take his words very seriously. Last but not the least, Dr. Mohsin Fareed is our radiation oncologist. He was trained here at Shaukat Khanum, and then he went abroad, and he's been trained in radiation therapy, and he's doing justice to all his patients. One of the integral part of our team. Whenever we are in problem, he accommodates our patients and give early time for them. So I will share my screen and we'll start the case presentation. And I would like to, I would request all my panelists to please unmute and share your videos as well. So you can see my screen?
Yes, we can.
Okay, thank you. So I'll start off with this because we have 25 minutes and I really want to complete this case. This is regarding a gentleman, 55 years of age. He was married and with no comorbids. However, his mother had gallbladder cancer and she died at 60 years, but her sister, who had a carcinoma of unknown primary, was treated at United States and she was alive when he came to us. So he presented for the first time in end of November 2011 with a left thigh swelling for 5 months. So Kashif, are you with us?
Yes, Dr. Kulsum.
Okay, so I'm showing the scan and please take us through this.
So these are the few MR images. On the left, you can see a sagittal T2. On the right, you can see axial T1 weighted sequences. Here we can see a soft tissue signal intensity mass, which appears intramuscular due to the deep fascia closely applied to the rectus femoris and sartorius muscles. The size is more than 5 centimeter. I don't have any post-contrast enhanced images to comment on the degree of enhancement, but given the location and size, this looks like a soft tissue sarcoma. This doesn't have any obvious intralesional fat component or calcification. So selected image through CT chest, not demonstrating any suspicious nodularity.
And his bone scan was also negative for metastasis. So we had a true cut biopsy from the mass, and Dr. Sajid Mushtaq, please.
Basically, it shows a myxoid neoplasm, and one can see a very elaborate network of capillary-sized vessels throughout the tumor. This is a low-power view, and one cannot see the lipoplastas themselves, but this actually is a myxoid neoplasm, and at this low power, one of the main consideration would be myxoid liposarcoma.
Thank you very much. So at the end, if we have some time, I would request Dr. Ilyas Rafi to please comment on. In this case, we were very lucky that there was no needle biopsy or there was no handling with the mass, because most of the times we see that our patients have incisions which are vertical to the skin crease lines. So Dr. Ilyas Rafi will elaborate maybe at the end.
Yeah, looking at the MRI scan, it's quite resectable, and we can also achieve wide margins. It should be resected at this stage, of course. Yes.
Thank you so much. And this is what we did. He underwent wide local excision in December 2011, and this was the pathology.
Again, the low power view, and you can't see the details of the cells, but a lot of stroma is, yes, this is a better view. You can see again that it is very similar to what we saw in the earlier biopsy, that it's a stroma is myxoid throughout, and then the darker areas you see are actually blood vessels, and they are present. A very regular sort of vascular network is present throughout the vessel. So this would go again with myxoid liposarcoma.
Thank you so much. And this was the question with us: should we give him adjuvant chemotherapy, radiotherapy, or surveillance? So because myxoid liposarcoma, I know Dr. Kazmi has shown some data from JAMA from 2021, in which there was a good role of radiotherapy for myxoid liposarcomas, but we are talking, this patient was in 2011. Dr. Kazmi, your take on this?
Yeah, so can I ask what was the size of the tumor and the margins on the surgery?
Margins were negative and it was 4.5 centimeter in size.
Yeah, so myxoid liposarcomas do have a particular tendency to recur locally, but they are low-grade tumors. This is a relatively superficial tumor. Now I would have a chat with my surgeon about the risks of local recurrence and the possible surgical options. And if it was, I think there was a chance of good surgical salvage and recurrence. For a smaller tumor, clear resection margin, surveillance would be perfectly appropriate, I think.
Okay, thank you. Dr. Mohsen, do you agree with this? Mohsen Fareed, are you with us?
Yes. Yes, I totally agree with Dr. Kazmi, as he elaborated very nicely that it's a low grade, size less than 5 centimeters. So I at that time also, I was totally fine with either observing this patient and keeping the option for salvage surgery in the future.
So this is, we are talking about, the patient was in 2011. He remained on surveillance with scans at regular interval, and then 4 years down the lane in February 2015, he presented with lump in left thigh, and that was at the site of his previous surgery. And this is the scan. Kashif, can you please?
Yeah, so these are the two MR images. On the left is a T2 and on the right is the T1. We can see a small rounded recurrent lump just on the superficial aspect of the surgical scar. So this lump is within the subcutaneous tissues, superficial to the deep fascia. There's no involvement of the underlying vessels. This looks resectable considering the MR appearances and is consistent with the local recurrence disease.
Thank you so much. So, and this was the lung images from the lung.
So there were no lung mats on these images.
Okay, thank you. So it was a solitary local recurrence with no metastatic disease. We did an ultrasound guided core biopsy.
Because this lesion recurred, we were interested to see in this myxoid liposarcoma, because some of the things which are associated with recurrence from the pathology point of view are presence of necrosis and round cell component. So we went back and looked at the initial biopsy which you showed earlier. There was no round cell component in the initial biopsy. And in this also, you can see some cellular areas at the periphery, but it's a very small percentage of round cell. Otherwise, it is very similar to what we saw in the first tumor. So it is again myxoid liposarcoma, no necrosis, and less than 5% of round cell component.
Locally recurrent. So he, following this, because it was histopathologically proven, he underwent left inguinal lymph node dissection. And this is what we had at pathology.
Very similar to what was seen earlier. And you see some cellular areas, and which we thought was probably some round cell component this time, a little bit more than what was in the first biopsy at the 2011. But still, you know, the figure which is used is more than 25% or not. So this is still less than 25%, maybe 5 to 10%, you know, overall. Yeah. So the cells are round. Now the round cell component has started appearing, which is one of the things which is known to be associated with recurrence.
Okay, thank you. So Dr. Kosarbano, can you please guide us? What should be the treatment plan now?
In this case, as it's a recurrent case, and there are increased number of round blue cell tumors. So obviously now it's progressing also in the grade. So in this case, after local resection, we will, as these sarcomas are chemosensitive, so we would prefer to give the adjuvant chemotherapy.
Thank you so much.
Though adjuvant radiation is also a possibility if it's only locally recurrent, but as again the grade is increasing, so adjuvant chemotherapy I think should be offered to this patient.
So thank you so much. But we discussed it at our weekly MDT and adjuvant radiotherapy, because there was no other disease and whatever recurrence was there was taken out. Adjuvant radiotherapy was offered. Dr. Mohsen, do you agree with this?
Yes, I totally agree, because this was recurrent tumor and the grade was also progressing. So that was a very valid option to offer adjuvant radiation at that time.
But the family, they declined the option of radiotherapy. They were afraid of the post-radiotherapy complications, and they chose follow-up for this patient. So now this time in May 2016, there was a lump in the left inguinal thigh region, and Dr. Kashif will briefly explain these images.
Yeah, so this is the MR which was done a year later than the previous MR. We can clearly see the increase in size of this mass, which is now more deep to the fascia, encasing the femoral neurovascular bundle around 270 degrees of the circumference of the artery. So it's a progressive local disease within the intramuscular compartment of the thigh.
And luckily, the lungs,
yeah, they remain clear for any metastasis.
So Ahmed Shoaib, are you with us?
Yes.
So can you please tell us what should be done for this gentleman now?
I think because the surgical bed has not been irradiated, so I would go for resection.
So what type of resection, Shoaib, you or Dr. Ilyas?
I think in my situation, obviously, all these cases, including this one, it was the tumor next to the vessels. When we see patients, as Professor Lee just talked, we usually see them very next to the vessels. So getting a wide margin around the vessel is usually not possible. So I would get a wider margin in which the vital structures are not destroyed and take as much as I can take out.
So Dr. Ilyas, your take.
Yeah, in this particular case, it's not that the vessels are draped or attached to the tumor. It is a total encasement of the tumor, the encasement of the vessels by the tumor. And when we say this, I think this MRI, I think we have missed the boat. If the tumor is lying away from the vessels or close to the vessel, there's so many things you can talk about. You will save the vessels, you will sacrifice the muscle, you will do the transfer of tendon to restore function and so many things. But once the vessels are encased, I think we miss the boat unless you have a vascular surgeon. We have done a few when Dr. Sami was here, and the swelling was lower than the saphenofemoral junction, so you could tie the vein and reconstruct the femoral artery with the Seminosphere graft from the other leg. But then here again in this, if you don't have a vascular surgery support, and the vessels are encased, I think the only thing to offer here would be an amputation. And since it's very, very high, we should go for hip disarticulation.
Thank you so much. So I think this was the discussion which was made by the orthopedic team with the patient. Hip disarticulation was offered, but the patient and the family, they declined and they lost to follow up. So the patient went outside, he saw other orthopedic surgeons and then came back to us exactly 1 year later when there was an increase in the size of the lesion. And during that time, he underwent a failed attempt, which was open-close surgery. And now he was with us again. So this was the recent MRI of the same patient.
So this clearly shows interval progression with complete encasement of the neurovascular bundle. As Dr. Ilyas said, it was very challenging on the previous MRI. In this case, you can see complete encasement, more around 360 degrees of the encasement of the vessel.
And the systemic scans, CT of the thorax was negative. And now, what options do we have for him? Local recurrence, not salvageable, no distant mets.
Yeah, here again, it's a large tumor and encasing the vessels, and it's growing fast. And patient have already been going around, have attempt on it already. So I think it should be done with hip disarticulation is possible. It's not gone into the pelvis or gone worse. So hip disarticulation would be done as soon as possible.
I agree with Dr. Ilyas on that. I don't think there is an option of excision, but if there is a case of vessel reconstruction, as Dr. Ilyas said, that it was done in our institution, and this is the area where you can reconstruct the femoral vessels.
Okay. And Dr. Kausar, you agree with them?
Yes, when it's localized and there's no metastatic disease, so surgical option, whether disarticulation or with the reconstruction, should be an option.
And obviously the vessels are draped 360 degrees. So I don't think neoadjuvant chemotherapy will help and will shrink the cancer to an extent that a limb salvage can be done.
Great.
Yes.
So again, he was discussed in our sarcoma MDT, where hip disarticulation was offered, and this time he agreed to it. And this was the pathology, and it was the same, Dr. Sajid?
Yes, again, it's very similar to what we saw earlier, and the cellular areas are actually more, you can see the very nicely vessels, exostoma, but it's now more cellular. So very similar to what we saw in the earlier picture,
Thank you so much. Dr. Mohsin, will you offer him radiotherapy?
So what was the size this time, and what about the margins?
Margins were negative and size was around, I don't remember, it was 8 or 9 centimeters.
Yeah, and also like in the last recurrence, we already discussed that he is the candidate for radiation treatment. So at this recurrence, especially with high grade and second or third time recurrence and with size of more than 5 centimeters, I will offer post-op radiation.
Okay. Dr. Atar, will you do the same?
I think he had a hip disarticulation, didn't he, the last operation? So post-ablative surgery, the role of adjuvant radiotherapy is very uncertain unless there are closed margins. So I think maybe Mohsin didn't realize that it was ablative surgery. If it was a limb salvage surgery, I would certainly give adjuvant radiation. But for ablative surgery, I probably would not consider radiation unless there was closed margin. Can I just comment on the sort of before pre-operative scan? So I would totally agree with my surgeons that the surgical option was ablative surgery. But just to keep in mind that mixed liposarcomas are relatively radiosensitive. And if the patient is completely adamant not to have ablative surgery, then I think the high dose radiation in the range of 65 to 70 Gray would be an option to provide local control. I think I would be very honest with the patient saying that this is inferior to surgery. This is not a curative option, but there is a chance of providing local control in more than half the patients with this sort of approach. So that would be one option, although certainly inferior to the surgery. Post-operatively with post-ablative surgery, negative margins, I would not give radiation.
Thank you so much, Dr. Atar. And the patient didn't give us time because once the orthopedic surgeon talked to him regarding hip disarticulation, he absconded and he came back to us after a year with a huge local recurrence.
Yeah, that's a challenge. That's a challenge that patients shop around, and unfortunately, that leads to suboptimal outcomes. Yes.
Agreed. So he remained on follow-up, and then on follow-up scans in July 2019, although he was clinically asymptomatic, we had an MRI scan, and Dr. Kashyap will please explain this to us.
Yeah, on this MR, you can clearly see there is a hypertense lesion within the left iliac blade, another lesion on the right iliac blade close to the posterior iliac spine, and a similar marrow infiltrating lesion we can see in the L4 vertebral body. So given the signaling characteristics, these are consistent with osseous metastasis in this patient. So again, another same lesions we can see on this view. We can see the asymmetry of the both hemipelvises due to previous ablative surgery on left side. So lungs remain clear for any metastatic nodule.
Dr. Kausar, your comment on this now?
Now, obviously, it's a metastatic disease, so we need to consider the systemic therapy now. And again, depending upon his performance status, either single agent IFOS or even in the metastatic setting, as we can also offer the trabectedin depending the BRCA1 mutational status, we should talk to the family. We should have talked to the family regarding this, and I am sure you would have done the same.
Yeah, thank you so much. So we offered him palliative chemotherapy, and he had some problems with tolerating the chemotherapy, but eventually he completed 6 cycles. However, very soon he came with excruciating backache, and these were the scans taken on that time.
So we did the whole spine MR for this patient. We can clearly see there is L4 marrow infiltration involving the vertebral body as well as the posterior elements. There is no osseous expansion. There's no central canal stenosis, no caudicuna compression. And the previously seen metastatic lesions within the iliac blades, they have increased in size. So progressive osseous metastatic disease with new lesions in the spine, but no caudicuna compression. We did the PET scan, so we didn't see any avid lesion in the rest of the body we imaged.
So it was a localized disease. However, a CT guided biopsy of T4 vertebral body was done, but it was negative for any metastatic disease. So what are the options now? Dr. Attar, Dr. Kausar, Dr. Mohsen?
At this stage, when patient has already received one line of chemotherapy, and obviously if the performance status is not well, in our setups and in our populations, usually patient don't tolerate the second line therapies. So supportive therapy is one of the options to this patient. If the patient performance status is good, patient is relatively young, then we can give some palliative chemotherapy. Otherwise, in poor performance status patients, supportive medicines are enough.
It's a very fair and very...
Can I comment on this?
Yeah,
so,
sure.
Yeah, I think clearly this is now not a curable patient, so we know that. But we also know that he has a relatively slow pace of disease. It's been going on for almost 8 years now, with suboptimal treatment because of his own choice. So, but his disease is slow pace. It's not curable, but there are a number of things that we can do in terms of improving his quality of life. So for one thing, if he has a lot of backache that's related to the progressive metastasis in the lumbar spine, the options are that I think he should be considered for decompressive surgery, and maybe my surgical colleagues can guide me whether there's an option of cement injection for these patients. That might help his local symptoms. The other option would be actually is local stereotactic radiotherapy, because that provides quite good symptom control in patients with vertebral metastases. There is a risk of collapse, and I can see that there's a significant amount of body is involved. So surgery is probably a better option, but surgery followed by local stereotactic radiotherapy would certainly improve his quality of life, improve pain control, and reduce the chance of caudiconic compression at a stage.
So the patient wasn't very keen for radiotherapy, and we offered him oral agent as well. But that was declined by the patient and the family, and they chose to stay on pain medication and zoledronic acid. With this treatment, his improved symptomatically, and the subsequent MRI showed that there was no interval change and there was no progression of the disease. So now this time, after 8 to 9 months, we saw him in clinic, and there was abdominal distension, pain, and constipation. There was clinical disease progression, and this was the scan we got for him. Kashif, please.
So on the CT scan, we can clearly see a large intra-abdominal soft tissue mass centered within the mesentery in the central and left hemi-abdomen. Can be seen on the coronal image displacing the bowel loops. So unusual site for intra-abdominal mesenteric metastasis from a sarcoma.
But myxoid liposarcomas are known for to metastasize to the retroperitoneal areas. So Dr. Attar and Dr. Kausar, he was in good general condition. ECOG
I think as a radiation oncologist, there's not a lot that I can offer.
Dr. Kausar.
If patient is in good physical condition, then obviously we can choose between, depending the family's wishes, if we can give him chemotherapy or oral agents, as they have already refused a lot of time to any therapies post-operatively. So these options can be discussed with the family.
Thank you so much. By that time, the next level gene sequencing was available in Pakistan. I talked to the family and explained to them, but they refused, and reasons being financial toxicity at the top. And then after spending so much money, there might be no targetable mutation seen. And even if a targetable mutation is seen, the agent might not be available in Pakistan. So after this, I offered him a combination of gemcitabine, docetaxel. I know that a combination in second-line setting doesn't give a superior disease-free survival, but since the response rates with a combination are better than a single agent, I thought that combination chemotherapy to give him for 3 cycles and maybe de-escalate as per the response. Do you agree with it, Dr. Kauser?
Yes, I totally agree with you. And although as I already told that in this histology, the trabectedin has a 50 to 60% responses, and obviously it's not available, but unregistered, it's available in Pakistan. It can also be offered to this patient. But again, the performance status, the condition of the patient, tolerability matters when we offer him a combination or even trabectedin, because I think at this stage, as I haven't seen the patient, but you might be the better judge. What should be done for him?
Yeah, thank you so much. Kauser, at Shaukat Khanum, we cannot give unregistered medication, and only those which are available or which are imported for the patients from abroad can be given. So unfortunately, after 3 cycles, this was the state of affairs. Kashif?
Yeah, we can clearly see that there is a rapid progression in the disease within the last 3 months. The burden of intraperitoneal metastatic disease has almost 3 times increased in size, with development of ascites and possible peritoneal disease. So in this 3 months time, disease has almost 3 times increased in volume. One should think about any further malignant transformation, any aggressive transformation in this tumor, because previously it was slowly growing, but in last 3 months, it's rapidly progressing.
He was clearly deteriorating by now. And then I had a family meeting, and the disease status and grim prognosis was explained to them. Further treatment was stopped, and the patient was referred to the palliative care physicians. Any comments?
Thank you very much, Dr. Kulsum. I have one question for the panelists.
Yeah, sure.
Considering we had a lot of discussion about neoadjuvant radiotherapy today, if this patient was offered neoadjuvant after his biopsy, would that prevented the local recurrence, considering the Professor Lee's talk? And I'll give you slight background that a lot of patients which we see in our clinics had biopsy from outside the hospital. And unfortunately, they have their compartments contaminated, as the surgeries are not done by people who are trained in sarcoma. So risk of local recurrence increases theoretically. However, in our clinical practice, we don't see that much local recurrence, and the metastatic disease, due to the extent and size of the tumor and delayed presentation, seems to be the main challenge. And I just worry that if we also start giving neoadjuvant radiotherapy to these patients and make an already technically difficult surgery even more technically difficult by doing so.
So I'll respond to that. So the first thing to say is that at presentation, I think the role of radiation was borderline, and with a small tumor low-grade histology, I think it was very reasonable to offer surveillance only. But at first recurrence, he certainly needed something more than surgery. He certainly needed radiotherapy. And whether it is before the second surgery or after the second surgery, we know that in terms of local control, both pre and post-operative radiotherapy are equivalent. So it doesn't have a lot of effect on the local control rates, but the toxicity profile is quite different. And personally, I would probably go for pre-operative radiotherapy before, at the time, second recurrence, because it's very clear that the field is contaminated, and surgery alone is not going to cure him. The other benefit is that actually by giving pre-operative radiotherapy, you can give a low dose of radiotherapy that has less toxicity. You can give 50 gray, and yes, there is an increased risk of wound complication, but as I said, as I pointed out from the data, that complication is something that is temporary. And yes, that probably makes the surgeons work a bit harder because the patients complain a lot to the surgeons because of acute wound complications. And then that becomes difficult for them to manage in the short term. But from a holistic point of view, that is something that is manageable. But this patient needed radiotherapy, certainly. At the time of recurrence, the first recurrence, the radiotherapy was advised, and that not taking radiotherapy at the time had a major impact on the future course of the disease. You can argue whether individual surgeons would prefer pre-op or post-op radiotherapy, and I think that that's a very individualized decision, and that has to be worked out within the context of the multidisciplinary team. But yes, radiation should be part of this tumor management at the time of recurrence.
So thank you so much, and I agree that radiation was indicated, but the thing is that this patient, he himself chose for this suboptimal treatment, and then he ended up with this huge recurrences and a poor prognosis.
It was probably my patient too. Maybe
yeah, it is. It is indeed. It is your patient, and maybe you'll remember his name as well.
Yeah.
The one thing more we learned from this patient.
And another thing, sorry, Dr. Kusum, I would like.
Yeah, go on, please. Mohsen, we can hear you.
Okay, so no, sorry, I was just saying that the option of palliative radiation will remain if there is any bony lesion or if he's symptomatic from that we can offer in a palliative setting along with the palliation that he is getting. That is the only thing that I would like to add. Otherwise, I agree with Dr. Kazmi that radiation should have been a part of his treatment either in pre-op setting or post-op setting.
On first relapse.
Yes, in the other thing can you hear me?
Yeah, we can.
Yes. The other thing we learned from this very case is that even when you do amputations like ablative surgeries, and radiation still has a place, because this one was a hip disarticulation very close to the pelvis. And like we said, in the hip disarticulations or amputation, we get wide margins and we don't consider XRTs. But learning from this case, I think we should consider XRT in the future. Just because we had amputation doesn't mean that we should not consider. That's my point. Just a thought.
No, I think, Dr. Athar, what Dr. Ilyas is elaborating is that once we are operating, sarcoma management is very different in the West. Single surgeon does the biopsy and takes the patient through various stages of treatment. Over here, because the compartments or the surgical fields gets contaminated at the stage of biopsy, it becomes a very difficult situation and a different situation as well. So we have to think out of the box. So although after ablative surgery, one would think that after hip disarticulation, you would not have local recurrence. However, we know that there is simply a connection through the femoral canal into the pelvis. So if the whole field was contaminated, you can easily get recurrence despite having an ablative surgery in these cases.
I think that's a very good point. But that's what I was trying to say, that so radiotherapy does not improve the risk of, reduce the risk of distant metastases. It is a local modality and improves local control. So if there was seeding through the vasculature inside the pelvis, adjuvant radiotherapy would not have helped that, because you wouldn't be treating the whole pelvis in this situation. And really, you can't give a meaningful dose of adjuvant radiotherapy to the whole pelvis anyway in this situation. So in this particular patient, I think every patient is different. And yes, after ablative surgery, it's very important to look at the pathology in detail, have a discussion with the surgeon. So it's not a sort of rule that you never give radiation after ablative surgery. But generally speaking, and particularly in this case, there was no local recurrence at the surgical margin after ablative surgery. And I think radiotherapy would not have improved things at all in this situation. He clearly had micrometastatic disease at the time of surgery. and that progressed eventually.
Dr. I've got one more question for you. So we very frequently see patients with 14, 15 centimeter incisions for biopsy, and they're big incisions on big tumors. And if there is an osteosarcoma or chondrosarcoma, in these settings, because you're saying that we can get better local control with radiotherapy. So if we do neoadjuvant radiotherapy in those cases, which we know are resistant tumors, do you think there is any role of that, considering, because there might not be evidence? I don't think there will be evidence on that, because in the West, there are needle biopsies, but we see big biopsies over here.
So my presentation was on soft tissue sarcomas. I didn't touch on chondrosarcoma or osteosarcomas, which are very different biological tumors. I think the role of neoadjuvant radiotherapy in osteosarcomas is very limited. The main role is neoadjuvant chemotherapy, and this is expected to not only prevent micrometastatic spread, but also hopefully provide some sort of local downstaging. But yes, for central or axial osteosarcomas where resection is not possible or margin negative resection is not possible, I think there is a role for individualizing pre-operative radiotherapy in these patients. And we do sometimes give it to patients who have either unresectable tumors or who are at a very high risk of positive margins, for example, high thigh tumors or pelvic tumors or central tumors. But the benefit of that is very uncertain. As you say, there's very little data on this. But I think this can be considered individualized patients. For large extremity tumors where the surgery is going to be ablation or anyway, I don't think there's any point in giving radiation. If ablation is going to happen, whatever you do, then what's the point of delaying it?
Okay, yeah.
I would agree with Dr. Athar totally that in tumors that are chemosensitive tumors and they are larger ones, and even now the guidelines also say that we need to go to the upfront neoadjuvant chemotherapy followed by surgery, and then depending upon the situation, the adjuvant radiation therapy. And other issue is that in our local centers, the surgical expertise are also limited. Post radiation therapy, the wound healing is a big issue. So whenever we talk in the multi-MDTs regarding neoadjuvant radiation therapy, our surgeons surgeons in the public sector, they are most of the time reluctant that for the pre-op radiation therapy, saying that it would be a difficult issue dealing these patients post radiotherapy.
Well, actually, in fact, if you give neoadjuvant radiotherapy and do the surgery within 6 weeks, I think the tissues are not that fried up, so you can do it, but complications is higher, there's no doubt. And once wound break down and you've got a mega prosthesis sitting underneath, it will be in no time get infected and you'll be looking at it.
You're right, Shay, but Kausar is talking about a public sector where getting hold of the surgeons is not that easy. Dr. Ilyas, please go ahead, and I'm getting signals from the symposium people. We have to wrap it up.
I'll just conclude regarding pre-op XRT. For surgeons, it's always a concern that it will cause radiation and difficulty in surgery and all that, which we usually get in adjuvant radiation. But neoadjuvant radiation, I remember one case very clearly. Dr. Athar might remember as well, his name was Hamza. He had a recurrence in his thigh, a big tumor, and there was obviously need to go in again, but he offered neoadjuvant radiation. And then after that, we got it out, and it's been about 3-4 years, and I'm doing the surveillance, and Alhamdulillah is doing fine with no recurrence. So previously he had the surgery and the recurrence somewhere else, and the recurrence was very quick. And I thought it will be a recurrence, but neoadjuvant XRT did make a difference. And so I think it should be considered. And finally, it's always a pleasure to see Dr. Athar Kazmi and all the team. Thank you.
The pleasure is mine, sir. It's a pleasure to be invited. Thank you.
Thank you so much.
Thank you, everybody.
Dr. Sajid, Dr. Athar, Dr. Kausar, Shoaib, Dr. Ilyas, Kashif, and Mohsin. Thank you all. Your valuable input actually made it, and we will continue working like this, like a team together. And Dr. Attar, we would like to see you maybe next time in person. And thank you and good night from my side.
Thanks so much.
Thank you, Dr.
Thank you.
Okay, Allah.
Thank you so much. Thank you.